I'm speaking here today, obviously, because I'm in the Research Services Unit in the Department of Health. But I think it's fair to say what I'm going to talk about today is really, we all, when it comes to trials, when it comes to new innovations, new technologies, new drugs, new treatments, it touches our lives in all sorts of ways. So I think I'm also bringing, they're not conflicts of interest, they're not disclaimers, but I think it would be wrong of me to say that everything that you're hearing from me today is with my lens from the Department of Health. Obviously, having worked in the Health Research Board and been part of that journey that Mairead discussed this morning, where I think in the space of 15 year, I have seen a situation from where I guess the ICORG, Anna, you mentioned ICORG there earlier, the 4 million a year at that point to ICORG, that was the sole investment from the Health Research Board and from the state in what I'm loosely calling the clinical trials infrastructure. And we have seen clinical research centres, the HRB's investment in clinical research facilities, we have the clinical research networks, we have the TMRN, that is a bit of a conflict of interest. I suppose I was involved in advocating for the call for a TMRN and the case for it, so I certainly have a bias in relation to all of the good things that are coming from that. But I'm bringing that experience and thinking in terms of my reflections here today. I've worked in industry, as Mersh said. I've had I suppose the privilege to actually go to the FDA with a dossier to try and convince them to give marketing authorization for a drug. One of the, I suppose, proudest moments in my life, seeing approval for that and knowing that a drug went on then to save and assist tens of thousands of lives after that. And at a very personal level, and I think there'll be many people in this room, found myself in the very I suppose, humbling and almost ironic position in sitting down with a family member, who, through all of your time working in research and working in trials and talking about randomization and talking about placebos and so on, you take it for granted, and then finding a member of your family sitting, reading the leaflet from an ICORG trial, and you fretting that perhaps they're on the placebo arm of the trial, and seeing that actually they don't mind about that. They're just delighted to have found a trial, to have an avenue, and to help other people. You bring all of that perspective to the table as well as your professional and your technical role. So that's really a large part of what is influencing my thinking in terms of, I think, what are more or less recaps. It's the advantage of being last in the day. You get to highlight and restate things that you heard others say that you really, really liked and resonate with you. And just to recap for us and bring it back to first principles, what has struck me from my time so far working in the department is the gap between the research world and the policy world. And even when it shouldn't be, for example, I'll use the example of the longitudinal study of aging, with a knee-jerk reaction going, but that's a big research study, that's nothing to do with policy. That's just, and that would be typical. Trials. I have a colleague here, Niamh, from the Patient Safety Office from the Clinical Effectiveness team. Now, having a conversation about trials and clinical effectiveness with that small unit is part of our normal business, and I'll explain. It is part of the decision making in the health system that is going on now with the incomplete, misreported and unreported and perhaps quality issues that we've just talked about. Outside of that, to a large extent across the department, and I don't think it's unusual in this realm, people don't see trials and policy going hand in hand necessarily. That connection needs to be made. The thread needs to be explained. The education, the awareness raising. Again, what has struck me is that the vast majority of people in a Ministry of Health have no background in health. And I know I'm going a little bit off-piste here of trials, but they're just important points to make, because we are in our conversations around transparency, communication, dissemination, what we refer to as policymakers are lots and lots of different types of people. But for the most part, particularly if we're talking about a government department or a ministry, that for the most part is not people who have a background in health necessarily. Their exposure to the health system as a user will be like Joe Public. Often what they hear about underground, what you hear in the media is your exposure. It is an organisation in the civil service that is, for the most part, made up of generalists who move from place to place. Now, I want to say quickly, everybody that I have met in the civil service, for the most part, goes in on the basis of trying. They have public service values and trying to work for the common good, which is absolutely fantastic. And the reason that I'm mentioning these points is, don't start your conversations thinking that people know what you're talking about. Start your conversations much earlier. Lay out the breadcrumbs of the trail that you want people to follow, because when it gets into some of the specialist areas, and we see some of the people in the rooms, the health, the HPRA, HICWA, the National Pharmacoeconomic Centre, I'm going to mention in a while, they are the agencies. That's where you will get the specialist people. That's where you get the people and the clinical effectiveness team who understand clinical effectiveness, cost effectiveness, who are feeding that into the decision making. But that they are small pockets, and sometimes people arrive into the department when actually they should be talking to these groups. And I guess I was just struck in terms of when we're talking about trying to change this paradigm, we need to be talking about the HSE, we need to be talking about HICWA, we need to be talking about the Pharmacoeconomic Centre, we need to be talking about the HPRA, we need to be talking about the professional training bodies and organisations, we need to be talking about the clinical care programmes. So that's just in terms of this movement, I guess, that we have, and in leading this, we need to think broader about the champions and the leaders that we need in that respect. I think it's already clear today that trials continue to play such a critical role in decision making in health. The drugs and products that come on our market, the decisions around how, we keep hearing about a resource constrained environment, we cannot afford to fund, no state can afford to fund everything where we know it's clinically effective. So decisions have to be made, and I guess what you've heard today is decisions currently are being made to the best of each agency's ability, but it is essentially with one arm tied behind her back because of the non-reporting, misreporting, delayed reporting, lack of reporting, and abandonment of trials and so on. And that's really, really critical. We've invested heavily through the Health Research Board in the systematic reviewing capacity in the country. It's absolutely critical. It was through systematic reviews and people pulling the evidence together from the individual trials that really started to highlight quality issues and missing data issues and so on. So I think that's been a really, really important development in an area where we've gone from sort of maybe a low base to actually having a huge leadership role, I think, internationally in that space through our involvement in the Cochrane Library and so on. And it's really, really important that that continues, because I think it has been the impetus and a driver. When I look around this room and I look at lots of people in the TMRN and in the trial and methodology community, I mean, they have been there from the early 2000s in the systematic review and the Cochrane community. So you can follow that trend through. I know we've talked a lot today about reporting, and I knew there is no way that you can do justice to the sessions that we've heard earlier, where you've got lots and lots of detail. I mean, the case is really, really clear. I mean, one of the points I thought I'd like to sort of hone in on for some of this session, particularly in light of the organisation or the network that has us here today, the TMRN, is, again, while all of that is happening, and I have no doubt that we're seeing it already through Ben and others, the reporting movement that is happening, and things are starting to change, both in industry and in academia. I just don't think there's any difference whatsoever. There's no differential between it. If the whole idea of doing trials is for better healthcare and better health outcomes for the public and for our citizens, well then it shouldn't and doesn't matter who performs the trial. So I think there just should be absolutely no, we're too busy, or we have more money, or you don't have money. I think that has implications for us in terms of as public investment in infrastructure and so on. I do think the resources and the costs involved in some of this, we need to get strategic. I think we need to join the dots. I don't think it should be researcher by researcher. I don't think it should be department by department. I'm not even convinced it should be university by university, and I do wonder if there's a conversation to be had with education and with the higher education authorities and so on, in terms of actually seeing what investment is needed for us all to do better in this, to basically put Ireland nationally on a better footing in respect of this. And it did strike me while Ben was describing how we really could become a very attractive and almost leadership and a beacon in respect of this in terms of attracting clinical trials. You know, it has always struck me, we're slightly later to the game often than most other countries are, but there is that kind of cute Irish thing about how we can sort of rob all of the good ideas and so on, and synthesize that and find ways of making things happen. We've done it with the smoking ban, we've done it with the plastic bags, you know, even when we weren't, I don't think we were quite sure what we were doing at the time when we became the first country in the world to actually subscribe for All Ireland Cochrane Access. I think it really dawned on us later on, actually, Jesus, that was actually really brilliant. How did we do that? You know, but again, it came from a champion and some leaders, and we did it. So I think there's a real opportunity to do that and actually turn that into a competitive advantage for Ireland. But the point that I really wanted to stress today, and it really struck me when we looked at the at the presentations earlier by the four Ashlings, as they're now known, the quality of what we do, the questioning around methodological research, is absolutely and utterly critical. So yes, we need to do better on the reporting front, but as Ben and others have said, if we're not asking the right questions, if we're not designing it to answer the questions that we've asked, I would argue more from being in the department, if we're not aligning what we're doing in the questions in the first place to the users, at the end of the day, and I'm not convinced we are, and I think we've a lot to do in that space, and I know it's an area that TMRN and others in Trial Forge and so on, Sean Tweak and so on, are really, really interested in, and I'm like 200% behind them on that, because transparency alone is not going to deal with the issues that we've heard about today. We need to question the questions, get in under the outcomes. I mean, it's probably, certainly from my time in the HRB reviewing grant applications, not just in trials, but particularly in trials, you know, you can't even find in some of them what the primary outcome is. And that education, that awareness, that support, it's not good enough anymore, I don't think, for people to say, well, we didn't know. I know we've heard that a lot today, and maybe that has been a reason in the past. You know, you've got Consort, you've got Prisma, you've got Trial Forge, you've got the TMRN to email or pick up a phone to. Nearly every university has departments and entities there that are part of this network who can help. So I don't think that is an excuse anymore. But I think what has always been difficult, and hopefully it won't be as difficult now on the back of this discussion that we're having internationally and now nationally. It's great to have Ireland right up front and centre in this discussion, and thank you to the TMRN for doing that, because I think that is one of the big deliverables from investing in this network. I remember for many, many years, and I think it is fair to say that probably for about 4 or 5 years before phase 1, as you're now calling it, of TMRN, trying to make the case for why the state should be investing in methodologists. And it just wasn't sexy, quite frankly, at all, compared to at that stage, I know we were grappling with actually funding trials. But one without the other is not a good investment. I think that is certainly one message and lesson that I think we have learned. One will improve the other, one will feed into the other. And having people where it is a legitimate job, a full-time job, to look at how trials are done, to look at how we can do better reporting, to look at how we can get better recruitment and retention. And all of the issues that I can't even touch on today is absolutely critical. So in parallel and nested within, wrapped around, whatever way, whatever language you want to use, if we don't have people like the 4 people that we heard here today, and see that that is as important, if not more important, than zillions of people off running around doing trials, which is equally important, we're really not going to be at the races at all. And I think certainly in my 14 years in the HRB, that certainly is a penny that dropped for me. And I think it has been a long journey. It's been a short journey in some ways, because like I said, in 15 years, I think, we can now look not just from funding from the HRB. Obviously, there's charities, there's other organisations, there's a large investment in clinical trials by the industry in Ireland. But certainly, even within 15 years in the HRB, I mean, I think I saw a quote from Mairead there. I'm not sure how recent it was, saying even between now and the end of the HRB strategic plan, another 54 million would be invested broadly in this space. I mean, that is just absolutely and utterly phenomenal in a short space of time. But what the real opportunity is in a short space of time, when we're now listening to the talks that we're hearing here today from people who have been in the trenches, lobbying and advocating and trying to come up with solutions and leading from the front for decades. And having so soon to be able to engage with them, to bring that thinking in an Irish context, I think is going to be absolutely critical, because otherwise we will continue to make reimbursement decisions when we don't really have the full picture about what we're comparing the new drug, medicine or device against. We're going to be in a situation where we have healthcare professionals who are absolutely, to the pin of their collar, hugely dependent on the wonderful thing that is clinical practice guidelines. For all the right reasons, complying with clinical practice guidelines that actually we can't say is actually based on the full picture. I mean, that is the sad reality, but it is the reality of basically what we're hearing today. And I guess I'm struck, it's just a comment, but I'm struck today by perhaps the question that Ben asked in terms of, how many doctors or physicians are in the room today, and that's partly because they're absolutely to the pin of their collar out there. But I do wonder, and I'm going to throw it out as a question, again, in terms of the doing of the trials versus the thinking of how the trials are done and how they are reported and all of those issues. So that's more like a rhetorical question that I'm throwing out there, but I think it is something that we need to reflect on. I'll go first. I said earlier that I feel reasonably old in this room. There's a very young, dynamic group here today. That's fantastic. But question mark for me, again, is this the people who sort of are doing the trials? It's our business to do the trials. And it's other people who worry about the how we do the trials, how we report the trials, how we up recruitment retention, how we deal with missing data, all of those issues. I'm being a bit over dramatic for effect, but I think it's a question that's worth posing ourselves. We need this is a great movement. There's great leadership, and we have to do it, because otherwise, and I know I keep repeating myself, we will not have sound and evidence-informed decision making in medicine. And if people, and I guess I see this from the department, if you're looking at the gold standard, which are trials, and you're looking at clinical practice guidelines and so on, there is a danger that the conversation, certainly that I'm involved in already in the department, which is very much trying to place evidence, say this is evidence, it's important that you do this, you put it on the table, that there will be the knee-jerk reaction of thinking that most evidence is not credible, is not trustworthy, and therefore almost is an excuse not to involve it in the decision-making process. So I would say there's an extra onus of responsibility on the trial world to try and work through this and to get it right. I think the opportunity from that is, as we move into talking about broadening the open data discussion and transparency more broadly in research, I think it's equally important that whether it be pragmatic trials, observational studies, preclinical studies, the recent discussions that are going around implementation research, context is key. Context is absolutely key. And again, it's something, a reflection from my brief time in the department. In terms of the policy, health policy analysis and health policy development, I would say, looking at the kind of you start to get into the researching around these things when you move in. Well, how should policy be made? And how should this work? And in terms of something like, the kind of health policy triangle, it's context, content and process. And I would say at the moment, content is not even on the triangle. And so a large part of my role in the unit that I'm in is trying to, firstly, because time is always of the essence, to take the existing evidence. And you're relying on the existing evidence, because job number one in terms of trying to change a culture and trying to get more evidence-informed decision-making in somewhere like the department is job number one is get the evidence, synthesize the evidence, and put the evidence on the table. We can have a whole other discussion another day, and I think Derek touched on it earlier about, transparency in decision-making. So if you do have the evidence and it is reliable and it is on the table, well, what decision ultimately gets made and how is that made? And certainly I'm not here speaking out of both sides of my mouth, because I think that is equally a conversation that is absolutely to the fore and needs to happen. So it's transparency in trials, transparency in research, but also transparency in decision making when we put the evidence on the table. But I think from what we've heard today, nobody could argue with the fact we're putting evidence on the table. It's the best available evidence, if you take the definition of sort of evidence to inform decision making. It's not collected in a transparent manner. It's not as systematic as it can be, and we know where we're going wrong. We know where we're not doing good enough in terms of how we're designing it, how we're reporting it, and everything involved in there. And it means education. It means training. It means awareness raising. It means advice and support like the TMRN gives. It means really getting serious about methodological research. I think that is an area where Ireland, quite frankly, can play a real role, linked to, through our transparency in reporting, trying to develop a competitive advantage in terms of being a country who questions what it's doing, and whatever it does do, you can be sure it's going to be transparent and open about its reporting. So for me, this is less about volume, it's less about quantity, and I think it's an area where we can bring real quality, and there's a real opportunity there. I mean, I can't conclude really without bringing it back to basics. I mean, the Department of Health, a research funder like the HRB, all of us in this room, regardless of what setting we're in, and I think it's very clear today, we all have a role to play, whether a researcher, a university, an agency, a department, whether the media, journal editors, and I think other departments, like I said, like education and so on, we need to get into this discussion. But the whole idea of spending any investment from the state, particularly from health and from the Health Research Board, is to improve patient outcomes, to stop people from becoming unwell, and to focus on health and well-being. And then when somebody gets ill, to keep them as well as they can for as long as we can, in a fair and equitable fashion, and to improve their quality of life. And I think that, at the end of the day, aside from anything else that we've heard, has come across through all of the talks. And we can dive into the details of the specific numbers and timelines, and whether we focus more on protocols or whether we focus more on individual data and all of these issues. And they're really, really important. And I'm so delighted to hear about all of the movement and people picking on those sort of multifaceted and mutually reinforcing. But I would like us to sort of wrap up at the end of the day in thinking, this has to change, no matter how difficult it is, no matter how resilient and persistent we have to be, and we've seen evidence of that today. This has to change, because what it says is that at the moment, we're making poor decisions. And it's impacting on people's health and safety, and ultimately, there will be people dying unnecessarily because we have either not improved the questions we're asking, the quality of the work we're doing, or because of under or misreporting of trials. And that's quite a dramatic statement, but it is actually the reality that people are being harmed in this process. So I think that is the key thing to leave it, certainly the key message for today. And I want to end by thanking the TMRN for hosting this event and for getting such fantastic keynote speakers. It's exactly the type of thing, I think, when the kernel of an idea of funding a methodology network many years ago was exactly this. This brings a broad church. We don't have people in disease-specific areas. We don't have groupthink. We have people across a whole range of different settings, and I think, and we have methodologists, we have trialists, and we have whatever you're having yourself. You don't have to put a label, because absolutely the main message we've heard today is everybody in this room, no matter what setting you're in, has a role to play in doing better trials, and reporting more trials, and then learning from what is reported, and understanding that research about research is as important as doing the primary research, if that's not too confusing. And I don't say that lightly, because actually it has been about 10 to 15 years of constantly having those conversations and seeing the movement happen around that has got it to that point. So I just don't want you to take it for granted, the people that have come in on in more recent times. So thank you for your time. I'm sorry you couldn't see my presentation. That's okay. And it was a bit around the houses and a bit waffly, but hopefully I'll send on the slides and share them. And I look forward to all of you, because in a department of health, there's a limit to what you can do in relation to this. We're completely and utterly dependent on the Health Research Board, the HPRA, HICWA, and all of you in academia to know the detail, to wave a red flag, to look for the change that you want to happen. So I would just say, be active in your discussions and in your approaching us around transparency, around quality, and around methodology. Don't be passive in that regard and assume that people sitting in a ministry or some other department understands the nuances and the specifics of the world that you're in. So I'll probably come to regret that, but I would say continue to be active, to be vocal, to try to work together, because this is challenging. It will cost time, money, and effort, but if we work together, and that is the advantage of a network like this. So thank you for your time.